Welcome to the village. Joan is looking at me strange. Here's the episode we've all been waiting for with Joan. Go ahead and introduce yourself for those that don't know her.
I'm Joan Venerosa. I am a physician's assistant. I've been practicing family health and pediatrics for the past 50 years. I was a pediatric nurse for 17 out of the 50. Have been a PA since 1978. Have worked in urgent cares. Have worked in emergency rooms. Always had part-time jobs along with my full-time family practice or pediatric jobs.
Currently,
I'm working for St. Mary's with Dr. Majid in pediatrics and pretty much doing strictly pediatrics.
Yeah, you're lucky. The two of us work side by side. Here's the best part, right? Yeah, pediatrics. I mean, that's always dear to your heart. Yeah. So that's why I figured we should get together and talk about what we do, because we are out of the office. You and I are strictly pediatrics.
Yes.
We're the only ones, well, Dr. Comer on Wednesdays, but basically you and I are the strictly pediatric providers. We work together. We take care of the kids. We share patients. So I thought we should get together and talk about what it is we do, why we do it, and talk about like frequently asked questions. The main question being, what is pediatrics?
Pediatrics, it's a specialty, taking care of newborns to children that end up being sometimes 21, 22, 23 years old.
Adolescents, yeah.
Depending on if they go to college, we keep them in the practice.
Mm-hmm.
Pediatricians are there to help parents monitor their children for growth and development, mental health issues, illnesses. That's why routine checks are very important for children, because all of that stuff is reviewed at an annual physical.
Yeah, we're there for the whole child. We're another piece of the circle of people involved in the care of children.
Right.
You got your main thing is your parents and caregivers. I say caregivers, sometimes it's an aunt, a grandparent, an adoptive parent, older siblings, and then you have your teachers, coaches, people in school, and then you have your healthcare provider, which we know health is not just physical, right?
No, you have to take care of the entire child. You have to take care of their health, their mental health, their dental care, their vision, their family health, how they deal with other children.
Yeah.
How are they doing in school? Religious beliefs, sexual orientation.
We may not have the answer or be able to help specifically down to the minutia, but we are a resource, like a navigator, right? So we either take care of it or talk about it, or then give resources or figure out if they need a specialist or who else to talk to. Who are the counselors available? Who else can they go to? And we do check in on the entire child. Because that wellness visit is
That's
so
what
important.
it's for.
Yeah, exactly. We check in on the whole thing. It's a long visit. It's not just like a quick visit. The physical part is like the quickest part.
Right.
We talk. We have conversations. That is why I insist on having a place to sit in the room. When I don't see my stool there, I get pretty mad because I like to sit down. I get tired, Joan.
I do too. No, I sit. I sit and talk to the parents. Yeah. Many times I'll have the parents hold the toddler. And I'll sit on that stool so that I'm even with the parent and the toddler. Sometimes it just makes it more comfortable for the child rather than being on that hard exam table.
And taking them away from their parent.
And it gives you the opportunity to interact with the parent more too.
It's nice to have that one-on-one, and I think a lot of parents, I know when I was a kid, I still remember some of these things. When you're with the doctor or the medical provider, the nurse, whoever in the office like treats you like a person, this is your appointment. We're not just talking about you or to you. We're talking with you. We're having conversation. You're the patient. You should feel like it's your appointment, even if you're 2 or 3 years old. It is your appointment.
Well, the parent knows the child better than you or I. And we learn about the child through the parent. And there are some parents who know their children better than others.
That's true.
So
The other thing is, like we were mentioning, parents don't always realize what we do versus what somebody else should do. But you can always, and you should always come to us as the starting point, and we can explain to you. Well, like if your kid is having trouble in school, I'll talk to teachers and guidance counselors, principals, and have that one-to-one conversation. There's a lot of conversations that are had, so there can be a full circle. Sometimes the parent doesn't understand what the school said.
Right.
And they will come to us sometimes with like this whole psychoeducational evaluation and be really confused about what is being said about their child. And we won't know unless we talk to the counselor or the teacher. And so if you give permission, some parents are astounded. They're like, you would do that? Yeah, of course. Like
well,
we could
the school
be that.
Counselors and teachers also have to be open to talking to the pediatrician. And many times that's difficult. And
if the parent kind of advocates and says, I want you to talk to the pediatrician, I will sign off. And when I say, I mean like every healthcare provider, because it's not just pediatricians that see kids. Family medicine providers do too. Right. So we have pediatric and family medicine doctors and mid-level providers. So PA nurse practitioners. So whoever your child's medical provider is, we can all take care of that child. Right. So it can be that connecting point. If you tell the school and you sign whatever medical releases or privacy releases to talk, they kind of have to talk to us if that's at the parent. I mean, I think sometimes there's this feeling of, we're coming in guns blazing. Like, we're not doing that. We're really just wanting to have a full circle conversation, right?
Right.
Like, I've attended meetings, even virtual meetings for kids that were in trouble for different things. And so kind of like as a character witness almost, like, I know this child has this problem or that problem, and that's why they did what they did. So the punishment should fit the crime, sort of thing. So you can advocate for your patient in so many different ways, but the parent should definitely let the school know that they would like that, and we will do it. And we want to help the child.
I have told parents when their children have gotten into trouble and that the punishment doesn't fit the crime.
Yeah.
To have the school principal or the teacher call me. Mm-hmm. Because sometimes it's hard to get a hold of them. It's easier for them to call me.
Yes.
Do they? No. Most of the time, not.
That's too bad.
Yeah.
They should.
Yes, they should. Because in my opinion, with what the parent is telling me for how that child was punished, it just doesn't fit.
Right.
So it is imperative that teachers and principals in schools and counselors communicate.
Yeah. We're all taking care of the same kid.
Right. And with what's going on today, it's more important to do that. Much more important to do that.
There are so many changes that I'm sure you've seen. Just to give a background, so I graduated medical school in 2010. I graduated residency in 2013. I've been here since 2014. So the changes and the things that they focus on in residency, are so different than what you see, because we don't do a lot of, maybe now it's different, I should go back and ask, but the psychosocial is so much a part of your day, and the mental health is just, it's definitely worsened. We've seen all sorts. Explosions, yes.
Yes.
The studies have shown that over the past even 10 years, 20 years, it's just exploded. And these children, just people in general, but, children, teenagers, that's our focus, because they're really the ones that we have to figure out. Yeah.
I think it's confusing for parents as well, because you hear a lot of things on the news, like just recently, the free-range parenting that I'm hearing about.
I just picture chickens in my head.
Well, that's how they're relating it to chickens. It's like, no, these are not chickens; these are kids.
Right.
You
don't say.
You just can't let them do what they choose to do. There has to be some form of guideline. Yeah. Sometimes I think that the news is creating issues for parents, because now the parent has to sit there and say, "Am I raising my child right?"
Yeah. There's too many voices and there's too little support for parents these days.
Right.
That community type of child raising where everyone's involved and everyone's responsible is much healthier, less stressful. There's more pressure on the individual parents than there used to be. And you can't trust the world, right? It's a scary place. It's a scarier place than ever before.
Right.
So much more with this. Oh, I won't even get into social media right now because I get a headache thinking
No,
about
but that
it.
leads off to the mental health issues that we're seeing with the children.
Yeah.
Goes right back to the mental health issues that we're seeing with the children, because sometimes there's not enough support at home and not enough support in school. A lot of pressure from peers. As a child provider, you sit in that room and you talk to these adolescents, especially.
Yeah.
The amount of pressure that they're under, it's very confusing to them.
Yeah.
And therefore they are either dealing with depression or anxiety.
And it's very rampant. And I just wanted to point out too that we don't have a lot of resources for mental health. They're very minimal. Right. We just don't have it. It takes a long time to get in to see a mental health provider. Less time for a therapist, more time for medication provider like a psychiatrist or psychiatry mid-level to take care of it. In the interim, or even just for the permanent, depending on what the issue is, we as the pediatric providers can do it.
And are becoming more and more the mental health provider.
We are. And in a way, some of it is good because they're comfortable with us. We've seen them for years and they'd rather talk to us than a brand new person they don't know. Because a lot of kids, adolescents are not willing to open up. Whoever they're willing to open up to, we are there for that. We can do that. And actually for quite a few of these teenagers, I've started many years ago before COVID. This whole thing blew up out of control. I was doing talk sessions. And the way it started was I had a teenage girl in here. She was maybe 15. She was very shy. She felt very awkward in her skin. She came from a somewhat religious family, which she was fine with. She was she believed in the religious Christian family. She was having a lot of anxiety, a lot of school phobias. There was kids picking on her, a particular set of girls. She wasn't comfortable opening up to a new person, and the parents did feel like a label would make it worse, so sending her to someone called a psychiatrist or a psychologist would make it worse. So they were struggling, but they wanted to help her. And I said, you know what, just talk to me. It was myself, and the nurse at the time was Michelle Wetz. She's since left pediatrics. She's still in St. Mary's. But the two of us would sit down with her for 30 to 60 minutes, depending. Granted, I had more time in my schedule back then. At least like 30, 40 minutes. You can kind of set 2 appointments and bill and justify the visit accordingly. But we would sit with her. We had several sessions with her, and we really helped. We just talked things out. She talked to us. We got to know her, and she felt better and stronger, and she still battles a little bit of anxiety here and there. We really helped get her out of that slump, per se. We really did it. Right. Then I've had these kind of talk sessions with kids that are willing. I've even had group family counseling. I've had parents sit around and just talk. Because sometimes all you need is that person to listen, or all you need is that person to be go-between to talk things out with. Right. So you may not need, many people do, don't get me wrong. I think everyone should have a psychologist or a therapist. I think we all need them just as much as you need your regular doctor or dentist. Everyone needs a therapist, but not everybody has one. If we can get kids out of that slump or figure out the problem either in the interim or just be that counselor for them. Some pediatric providers want to do that. Some may not. Some do. But just ask. That may be an option. I like to do it because part of it's the mind, body, soul. I'm into it. I like it, and I know you do it too.
Well, sometimes what happens is when you have a child come in for a school physical, you get into other issues. And that, half-hour visit ends up being an hour visit because you're sitting there talking to the child because they're having a problem.
Yeah.
And most of the time it's with depression or anxiety. And you have to sit and talk because you can't let them out of the room without really defining the issues and then know, well, you need to come back and see me next week just to sit and rap.
Just have exactly.
Right. Just to sit and rap, and
I love it.
We'll have a half an hour visit. Yeah. And I have a young lady that I've worked with for the past several months had a horrible case of like psoriasis and was seeing a dermatologist and wasn't using her medicine and wasn't showering and just wasn't doing anything, very depressed.
Yeah.
But if you see her now, she's taking care of her psoriasis. She looks like a totally different young lady. Yeah. And she's happy with herself. She's starting to go to FMCC.
That's awesome.
Starting to go to college.
She just had to
talk.
Exactly.
She had to have somebody kind of guide her over that hump, you know?
Yeah.
You're a pretty girl, but you're neglecting yourself.
Right. Care about yourself. Like, you can just be a person, an adult who lives in the world, and you can say those same things.
Right.
We might just be that adult.
Everybody finds somebody to relate to. And you know, I mean, if you can relate to a child, you are of benefit.
Yeah.
If you can't, well, it's not hard to determine whether you're going to help them or not help them. And that's when I tend to refer them to see if we can't find somebody that they're willing to talk to more than they're willing to talk to me.
And you need to be able to connect with your therapist or the person you're talking to. You know, so that's why sometimes it takes a couple people before you find a therapist you can relate to.
And that brings us back to those routine yearly well child visits.
Yes.
They're done because they have to have them for school. And those are important because you keep up with their immunizations, you monitor those, you bring them up to date, you make sure that they're getting their vision checked, that they're going to see the dentist. Those are all, and checking their hearing because the school does that, checking them for scoliosis. All those things we integrate into that visit. Sometimes it starts out as they're coming in for a school physical. Sometimes they're just coming in for an annual. But it's all integrated into that visit, including their mental health.
And you might pick up on other things that we ask detailed questions. Are you having headaches?
Right.
Are you keeping up with other kids during sports? Are you having issues breathing? Are you coughing? We might diagnose something they didn't realize they even had.
Well, how often have you picked up a kid with asthma?
Exactly.
That didn't know they had asthma.
They didn't know that they weren't breathing to their potential.
Right.
Like they didn't know.
Neither did the parent.
Yeah. They didn't realize. The parent didn't realize the kid was up coughing because they're in a different room and they may not know. And that's why I said the parent should not put all that pressure on themselves. Like there's like this parental guilt that happens. Just bring them to us. We will help you. We can talk to them and maybe pick up things that were not picked up. And headaches, too. Some kids don't even realize they have headaches. It's a normal thing for them to have pressure in their head. And we can make them realize, like, no, that's not, you're having headaches. There's something triggering. It's probably your cell phone, but that's a different issue. But no, I mean, there's other reasons for headaches, too. Some kids have
Well, I think sometimes it is the electronics. And I do have conversations with parents about electronics and the fact that those should be limited, especially in young children. When they're during school time, during that week, they should be limited to only an hour a day.
Yep.
And if on weekends you want them to be able to spend more time, that's fine, but I wouldn't go past a couple hours. They need to be playing. They need to be outside playing. They need to have their friends over. They need to interact with other children. Get them active. Get them into learning how to play a piano. Send them to a piano teacher. Get them involved. So there's not a lot of idle time. So that when they're home, well, now they can practice that guitar. They can sit and practice that piano. But something that they enjoy doing, not something that you're actually shoving down their throat like some parents do. No.
Yeah, whatever. Introduce them early to multiple things.
And get them away from the electronic.
It's a depressive little device. Like even if you and I are sitting at a computer or a phone all day versus go outside and do something, interact with people.
Which we do all day.
Yeah. Yeah.
We do. Because medicine is now computerized. And we sit at that computer all day. And we're on the phone.
Yeah, we have to be. That's how all our notes, documentation, results for things. Right. Like, you can't work without that computer. You know, I don't know if that's good or bad, but that's just the way the world is with the computers. Like, everything's on there.
But for children, you can take them away from it by taking the phone away at night. That's another issue that I find. Children with phones at night, on the phone, in the middle of the night, or their tablets. No. Those should be taken away when they go to bed. End of story. No more.
It should be taken away, I say, an hour to 2 hours before bed.
Well, yes, and research has shown that when you put your child to bed and they're on that phone right till the minute, their brain doesn't have time. It takes a long time for that brain to calm down, the stimulus. So they do recommend take any electronics away from them an hour before they go to bed.
Exactly.
And that's a recommendation
In
from
fact,
many
take
psychologists.
it out of the room. Don't even keep it in the room.
Well, they're doing research now showing that cell phones and tablets and all the electronics are changing the brains of our children.
Yeah. Yeah, it's very true. Okay, so we talked about the things that we might pick up at a well visit. Now, we can take care of a lot of these things. We can treat their asthma, their eczema. We can treat all of these things, their anxiety. There's many things that we treat. Sometimes we need to send them to a specialist, but I think the two most common things that I'm asked from parents to send to a specialist are belly pain and eczema. Now, we have many things that we will try to help you with because honestly, very few children have a chronic gastrointestinal issue that really needs a gastroenterologist. And I've actually been told by the dermatologist that we see so much more eczema than they do that it's best they stick to us because unless it's like that really bad eczema that's just everywhere and then they need specialized treatments. But, you're a pediatric provider.
You do everything.
We can take care of a lot of things. You don't have to go to a specialist unless we really deem that your child really needs a specialist. So, have conversations, try different treatments. I mean, some parents will really insist on a specialist. And what do you do when a parent insists on a specialist? What do you do?
I tell the parents that there's no need to send them right off to the dermatologist, let's say.
Yeah.
Because I have sent many patients to dermatologists. And what they do is they order medications that I can order.
Right.
So the parent now, because we have no dermatology services here in Amsterdam, you have to send them to Saratoga, Schenectady, or Albany.
Yeah.
So now the parent is going to take several trips back to that dermatologist for something that I could have done initially.
And you tried to do also, but...
And so I do that. When I get to a certain point where we're getting into medications that, as a pediatric provider, I'm not comfortable
like that we don't prescribe every day.
Right.
Yeah.
And that's when I will refer them to. I'm not adverse to sending them to the specialist.
Yeah.
I am adverse to making the parent drive back and forth to Schenectady, Albany, or Saratoga for something that I can do here.
Right.
So when we hit that limit, then I will refer them to the specialist. And most parents are comfortable with that.
Yeah, it's the same thing for something like a gastroenterologist, which now some of the specialists will come here one day a week. I can kind of get it. If you're very nervous as a parent and you really, for that peace of mind, want somebody else to give you their opinion too, I do get that, but we can have a conversation. It's not always necessary. We see a lot of things. We will take care of asthma and headaches too. Everything we take care. And that's my little background story. When I was in medical school, I love the subject matter of gynecology. I find it fascinating. It's interesting. I was always good at it from that standpoint of what it is, like reading and studying about it. Now, we do a 6-week OBGYN rotation your third year of medical school. And right after that, I did my 6 weeks of pediatrics. And over the 6-week time period, my whole brain just changed. My whole thought process, I was like, I can't do OBGYN. I must do pediatrics. It was calling out to me. First, I thought pediatric endocrinology was so cool because, you rotated in the subspecialties too. And I was learning about kids with diabetes, and there was a kid with panhypopituitarism. It was so neat. To me, it was so interesting because there's so much more diversity in pediatrics. You get to see so many other cool things. And then I saw a kid inpatient with asthma, and then I saw a kid with Crohn's disease. And so everything I was learning, I was thinking was so cool. And that's when I realized, okay, I need to do general pediatrics because, like everything,
Right.
we do learn and train in everything. We're not specialized in everything. So, yes, there's things beyond the
What we
scope
can
of a
do.
general practitioner. But we will take care of things. And the cool thing is we know who to send you to if need be. So,
Right, you have your standard list of referrals,
right.
and you tend to send them to specialists that you've already sent other children to
Yeah.
that did an excellent job.
Right.
So it's not like we're just pulling people off the internet.
No, we're not Googling who to
who to send them to. We have a list of who we send them to.
And we have people we interact with, and they know us.
Right.
In many cases, they know us or they've seen our names multiple times. So we know, I've talked to, and you've talked to the different GI doctors, cardiologists, infectious disease specialists. So we have relationships with these people. So we take care of things, and there are specialists if need be. So that's what we're there for, just pretty much everything. You can go from seeing a premature baby and taking care of what they're supposed to be eating, and then your next visit is a kid that just came out of inpatient 4 Winds, and you're dealing with the antipsychotics they're on. So we have a very interesting day.
Yes.
Sometimes stressful, but it's cool because I like the education piece. Did any part of you ever want to be a teacher?
No.
That was never. You were always medical and comedy. That's your thing too.
Oh, yeah. And musician. I played guitar and piano. That's where my son picked that up.
Oh, I didn't know he picked it up from you. That's so neat.
Yeah, that's where we picked it up. Doing pediatrics is something I fell into because I started actually babysitting when I was 9.
Oh.
For the 2 children across the street from my house.
Wow. See, times have changed so much. A 9-year-old still gets a babysitter nowadays.
I started when I was 9 years old. And then I started babysitting for a pediatrician in Amsterdam.
Oh, cool.
Yep, Dr. Tom Weil. I started babysitting for his children, who are now adults and friends of mine.
That's where it all started, huh?
Yes.
9 is an interesting age. When I was 9, in 4th grade, we had a project where we had to think of what we wanted to be when we grow up. And we had to find a person in that profession and interview them. And I picked pediatrician. And it's not as fantastical a story as it seems. It wasn't that I knew from then and it happened. Like I said, I had many thoughts along the way. But at 9, I took the yellow pages, remember that? The big book? And I looked up a pediatrician because I was seeing a family provider with my dad and stuff. So I looked up a pediatrician and I found him in the yellow pages. And I might have even made that phone call by myself at age 9 and gotten I don't know if my dad did it or I did it, but we got a time period set up, and my dad took me. And we sat there with Dr. Matthew Bolus near Cherry Hill, New Jersey, good old South Jersey.
Yeah.
We sat and talked. I made a list of questions, and I interviewed him for approximately an hour. My dad was sitting next to me, and he was sitting across, and we had this great conversation. Then he became my pediatrician after that. It's so interesting because the things he said, it was so different back then, right? Well, after that, I wanted to do pediatrics, and then there was many other things I wanted to do with my life. I even considered teaching at one point. Anyway, so then, like I said, I majored in chemistry, so that's completely glad I didn't pursue that. Definitely not my thing. Yeah, then I ended up where I am now. So there's ups and downs along the way, but that was pretty cool. I remember that.
The difference between you and I and today's children is that I had a direction. I knew I loved music, and I knew I loved children at the age of 9.
Yeah.
Okay. When I see children in the office today and I say, what interests you? The answer more often than not is, I don't know. So I will sit and kind of brainstorm. It really, if they're 9, I don't get into it too much, but when you're in 11th grade and you still don't have a direction, that to me is a problem, because I say to the parent, you have to help them find some direction. What is it you want to do for a living? What do you want to...
Yeah. What do you like? What are your aspirations and goals for this
many
life?
have no idea.
Because there is a lot of this dumbing down of the personality and the senses because of all of this TikTok and all of these things. Like, all you do is watch these people all day. It's actually pretty demoralizing. And it's not realistic because you can't just be a YouTuber for a living. And you can't just be an influencer. What does that mean? Influence people to do what?
Certainly not find a goal in life.
Right. And it's sad. It's sad for the kids that this is the world they're growing up in. It's not realistic.
No.
I was just thinking about this. I started watching this show on Hulu. I was looking for another series to get into. These people on the show, and I won't mention what show, but it was these 4 women, and one's a doctor, one's a lawyer, one's a real estate agent, and one is an interior designer who owns a store. They're so stunning. They're around my age, and they have these stressors in life. It's not that they're not stressed out like you and I, but they're so beautifully perfect and so fit. And even with all these issues in their lives, they still manage to just... I was like, where are they buying their dresses from? Like, they fit like a glove, and they look wonderful. How is their hair? There's no flyaways.
It's unrealistic.
Their eyeliner does not run. By the end of my workday, I have raccoon eyes. I just can't figure out because I'm yawning, and then you tear, and then the eyeliner spills over, and then there's the dark circles. Like, I can't just go home and look gorgeous and then make dinner. Like, how is this happening? And me at 41 started to feel like kind of demoralized. I was like, I need to get it together. I need to find better makeup.
Those shows are unrealistic.
And then I reminded myself, wait a minute, stop being naive. This is a TV show. This is not reality. Some of the themes in the show might be realistic, like some of the things that happen in life, but this isn't reality of how people look, people feel. You know this. Right. I told myself, stop being naive, stop being demoralized by a TV show. This isn't real life. And I'm not as impressionable as an 11-year-old or a 15-year-old. Right. They're looking at these things and they're feeling bad about themselves. And it's not real, but how do you tell an 11-year-old that? How do you tell a 16-year-old that? It's all they see, and it's all their peers are doing. See, my peers know better, right? But their peers, they're all doing it. It's such a difficult world to grow up in, seeing these things.
It is, and there has to be somebody in that child's life that they feel comfortable talking to.
Yeah.
And sometimes it's not their parents.
Sometimes it's not, and their parent may not have the capacity, the time, the mental wellness themselves, and that's okay. It may not be that parent. It may be a support group. That's what sometimes actually social media is good for, things like that. If you want to find a support group on one of these social media platforms, it's pretty good for that. Not always, but, or even locally, whatever group that's going through the same thing as you or a similar thing. So we were talking about, with that, how has pediatrics changed? I mean, as the world changes, we have to change our specialty, right? You've seen this, like I told you, in the past 10 years, I've seen a change.
Major change.
You must have seen the past 50 years, lots of changes. I mean, Dr. Bolus used to take house calls. Some of our local pediatricians who retired used to make house calls.
When I was a kid, doctors made house calls all the time. Mm-hmm. They didn't hesitate. It was a good thing because they got to know my mother.
Yeah.
Sitting in her setting.
Mm-hmm. Yeah, then you see the home setting.
Yeah.
I would love to, in theory.
In theory, yeah.
In reality, this world isn't built for something like that.
No, it's not very safe. And that's a shame. There's a lot of loss in what's happened over the years with how you could go to a house, you could feel comfortable. And those house calls were usually made after the office hours were over. And those were made between the hours of 5 and 8 at night. I did house calls when I was did a preceptorship out in Elmira when I was in PA school back in 78,
That's
76.
Interesting. That's where Dr. Gardner is now.
Yeah, it was the medical Sullivan Trail group or something. Mm-hmm. There was family practice, and twice a week the mid-level went out and did house calls, and I went out with him. Mm-hmm. It was interesting. We mostly saw elderly people who were homebound.
Yeah.
Not necessarily pediatrics. But that's one thing that's been a loss over the years. The other thing that's been a loss is that I find I tend to spend more time at the computer than I do with the patient because of all the necessary computerized medical record protocols that the government has placed on all of us. I find it annoying.
Mm-hmm.
I can remember walking in to do a visit when I worked with Dr. Weil. I was running his Fultonville office. I remember just having a piece of paper and a chart.
Yeah.
You could do a soap note and just fit 4 visits because all you wanted to know was, why are you here?
Yeah.
This is what I'm finding on exam. This is the diagnosis. This is what we're going to do.
Mm-hmm.
And that was about it. Now you have 3 pages of notes.
Yeah. Documentation is much bigger deal. And I remember when, people look at me and assume I'm fresher than I am, but actually I have much more tales to tell. If you look closely, Joan, you can see a lot of the white hairs. In medical school, it was all paper notes. There was some stuff on the EMR. You could find some things, but it wasn't the be-all of everything.
Wasn't as involved.
As a medical student, you didn't even really need a computer.
No.
It kind of started there. And then in residency, we were starting to switch over from handwritten notes to progress notes on the computer, which was a whole weird thing.
Right.
And now it's like sometimes if the computer system goes down and they give you a pile of notes to write, and I get so excited because granted, handwriting is difficult.
Yes.
You can't understand what people write. That was the stressor back then.
Yes.
But now it's the documentation.
There was always some nurse or somebody that could decipher it.
Yes, certain nurses were very good at certain providers.
But it wasn't as time-consuming, and you were more face-to-face with a patient. And I hear a lot of, especially adults, make comment to the fact that my physician is not listening to me.
Yeah.
Well, what makes you say that?
Yeah.
Well, because when I'm talking to them, they're doing just stuff in the computer.
Yeah. And we're listening, and you have to get good at interacting while typing. I've had 3 ENTs, and one of them, she looked at the computer. This was in Westchester County, not here. She looked at the computer the entire time she spoke to me. I don't think she looked at me once. Not once. And I don't think she cared that she didn't look at me once. Incidentally, that was the most painful scope I had. So I think there was probably a bedside manner issue there, and
I think that's what the patients and even parents pick up on, is that there's no interpersonal interaction when your face is in the computer and you're typing what they're saying. You're just not eye-to-eye contact with the mother or the father or the husband or the wife or the child.
Good. Granted, you're going to be here an extra 3 hours at the end of the day if you don't type during the visit.
Yeah.
However, there's a way to do it. You can be typing and talking and explain, when EMR first came or we had a new EMR, there was some switchover where we started to take computers into the exam room in my pediatric residency when I was doing my ER rotation. And they kind of trained us on it. They said, okay, now we're going to be taking computers in the room. It was a big deal. And they said, just tell every parent or guardian that you are going to be typing while talking, but that you're still listening. And you're only doing this so that you have more time to take care of their child after the fact. So just explain what you're doing. That's a good idea, because as we're typing, we are listening. It's not apparent to everyone. It is a necessary thing to do, but I guess we do have to be mindful of communicating to them that I am listening. I'm just trying to type what you're saying so I don't forget it later. There's a lot of stories coming my way. There's a lot of histories coming my way today, and I don't want to confuse them, so I want to write down, especially if you're bringing in 2 or 3 kids.
At the same time.
Who had the fever? Who had the cough? We're only human. We're only human. So a lot of changes, some good, some not as good, but a lot of changes. Things change with time, but the reason why you go into pediatrics and the reason why we're here every day doesn't change. There's many more things we could do for the same money, but we don't because we want to take care of the children. We're only here for that, which is actually, I'll talk about that later. That brings me to another question or answer. What is telemed appropriate for?
Well,
that's
again,
always
this
like
is a new
sticky.
thing.
Yes, that's another big change that's
Another
happened.
big change, telemed and videos, and utilized mostly for parents who are.
I'm putting it closer to you so that if you do look down, it'll still catch.
Okay.
I know you think that I'm nuts, but that's okay. Maybe I am. Maybe you're right.
We use those visits for parents who, number one, have a hard time getting out of work to bring their children. Number two, need sometimes immediate attention because the child's having a problem and they, again, can't get out of work to bring the child, or they don't have a vehicle at the time.
Mm-hmm.
Sometimes we do them because it's a little bit easier for us to fit a visit in,
Mm-hmm.
doing a video or a telephone call, where trying to get the child into the office would be more difficult because you have a full schedule and you just can't fit another one in. So they're helpful. It's very hard to assess over the telephone, even with a video.
Mm-hmm.
But again, with years of experience,
Mm-hmm.
you're capable of doing that. And if you're not, and if you can't assess the child well enough, then you have to bring them in to see them.
It's good for some things. Sometimes it's more of a tide over, right?
Right.
I think it's really good for mental health if they're willing. Some kids I've noticed like to be in their home environment and open up better than an office.
We use them for follow-ups too, for children that have ADHD that are just needing to come in for a med check. Basically, follow-ups can be done with videos. So it's helpful in that respect too. It saves the parent a trip.
Yes. Here's another couple things. And this is a perfect question for you. What is the urgent care and emergency room for?
I think that's very confusing sometimes for parents, and I tend to discourage visits to either because there's always, and with this office in particular, there is always a pediatrician on call from 5 o'clock at night after the office closes until 8 o'clock the next morning.
Yep.
So I encourage parents to call the office, talk to the exchange, and a pediatrician will get back to you and guide you as to what is best to do with your child. Most of the time, it's not to run them off to urgent care or the ER because the fever can be managed at home till the next morning when you can bring the child in to be seen. Urgent care is basically used for minor illnesses, minor lacerations, minor injuries, not heart attacks, not major lacerations. I think people get confused and you will end up with people coming to urgent care with heart attacks, pending strokes. Those are not things that need to be there. Those need to go down to the ER. Urgent care sees coughs, difficulty breathing, asthma exacerbations, and minor injuries like fractures. It's a very busy place. I tend to discourage parents from taking the children, especially if they're babies, because you will sit there for hours in the midst of God knows what is in that room with you. In that waiting room.
It's not faster than the ER by any means.
No, it's not. No, because you can sit, you have one provider most of the time in our urgent care center.
You only have one at a time?
And that provider can see up to 50 plus patients in a 12-hour shift. Well, 10-hour shift, actually now. That's in-out kind of medicine.
Yeah. It's not an alternative, let's say. It's not an equal alternative.
Right.
To your provider. If the office is open, they'll try to get you and they won't send you to urgent care. I don't like to use urgent care as a we're busy alternative. That's not the case.
And I think parents tend to circumvent our office because it's easier to go to urgent care because you have 3 children who are sick and mommy too. So all can get seen. Here we can see the 3 children, but not mommy.
But one of our other providers most likely can see mommy.
If one of our other providers is taking care of them. So that becomes an issue too, that you can take the whole family to urgent care. But at the same time, if everybody's doing that, you will sit there for hours and you're subjecting your children to everybody who's sitting there with you.
Yeah, because there's, especially right now with COVID, RSV, flu, not a good place to bring children. We're seeing positives for all of that. There's RSV and flu just everywhere.
Right.
I would just be more careful and mindful. And you want to see patterns and have a continuity of care. And we interact with each other too. Like if I'm not there for some reason and you or one of the family med providers see a child for something, you'll come and tell me, yeah, I saw such and such kid of yours and they had this thing going on, so I know. You don't want too many cooks in the pot of your child's health.
And the way to avoid going to the ER and urgent care is to call the office. Mm-hmm. So there's always someone during the week on call from 5 at night till 8 in the morning. And weekends, pediatricians cover 5 Friday night, right, until 8 Monday morning. Yep. So there's always somebody at the end of that phone that you can converse with and can guide you so that you're not taking. And sometimes the pediatrician will say, if your child's temperature is, hitting 103 and above, and you're not able to get it down with Tylenol and ibuprofen, they may say, take the child to the ER. But more often than not, whatever's going on with that child can be circumvented and postponed until morning.
And we can have that conversation even if it's in the middle of the night, but that is why we're there.
Right.
That's why we're here. Like, we want to do that.
Right.
I mean, we like sleep as much as the next guy, but we also don't want to know that you didn't call and then you ended up somewhere where we could have helped. We'd rather help you.
Right.
Do you have anything else that you want to mention? I was going to mention now what age group, like if you have a kid of your own, would you still go to a pediatrician, that sort of thing?
If I had a child?
No, I mean, if we had a teenager that has a kid. Well, I guess, okay, so we're switching gears here.
Yeah,
I'm confusing you.
You're losing me.
Okay, so that's when to go to the pediatrician. Now we're kind of switching gears into when to not go to the pediatrician. So like you had mentioned before about what age a pediatrics is for. Now, this is where I guess it really depends on the individual provider. When you're doing purely pediatrics, there's a cutoff, obviously. You wouldn't go to a pediatric provider your whole life because we are specialized in those things. I like to see children. I consider college-age children until you have launched into a life where now you're either working or parenting, whatever is now makes you more adulty. Or if you start... Adulty, exactly. It's a good term.
Yeah.
You can use it if you want to. Not feeling adulty today.
You transition. You actually, as a pediatric provider, you can determine if that child you've been seeing for many years has transitioned over to adulthood.
Yes.
Just by their behaviors, social changes, And you know when it's time to refer them to the adult provider.
And you don't want to, I don't like to have like a cutoff like you're 18, you're 21. It's not voting age or drinking age. This is pediatrics, Yeah. I like to see, like you said, their transition, their maturity, their willingness. If they're still having the same health issues and nothing has changed, if something becomes too, like, okay, now they're doing things that the adult providers see all the time and I don't see, like the major cholesterol problems, the hypertension, those type of things, they might want to transition over to a provider that sees adults too. But if you're in college and everything's kind of the same, I'm not going to push you out. You can't suddenly now have to transition into adulthood in one way and not the other. To me, it doesn't make a lot of sense.
An example, I have a 19-year-old who is going to college and is now away from home for the first time and not dealing with it well. Yeah. Very, very anxious. So she might be 19, but she's not mature.
Mm-hmm.
So we've had a lot of conversations. I did recommend that she bow out and maybe go to a local college like FMCC for a year or two and mature a little before she proceeds on to being away from home because she's not dealing with it well. Like I said, you can determine, are we going to that adult stage or are we not?
Yeah.
And at this point, she's not. She needs to mature more. So she might be 19, but she's not emotionally.
That's totally fair. Everybody's going to do things in a different way. And so it's very individualized.
Right. Exactly.
I had a 16-year-old boy. He was the elder of two boys. And he made the decision to stop coming to me and go and see one of our family providers because he wanted to be an adult. And that's kind of how he was raised, military dad. Everything was very orderly, and he really wanted to prove his adulthood already. It's like, by all means,
right.
You're
not going to discharge him from your practice because of it.
Yeah.
He can move on to the adult stage.
Yeah, right.
But he always has the option if he wants to come back.
Right,
That's how I look at it.
Exactly. We're always here. We're keeping a light on for you. I keep children who became parents, and I see the teenage mother and the teenage father and their child. I don't have a problem with it. Some pediatric providers do.
I still do have a few adults in my practice from being in family practice who there's your case scenario, as young individuals became pregnant and had children, and now I take care of them and their children. So it happens.
It's kind of a beautiful thing. I wanted to point out that a healthy child is a blessing. It's not something to be taken for granted. People think pediatrics is very cute, and a lot of parents have a lot of sick children, and the world doesn't know about it because those sick children aren't at the park and they're not in the regular schools. But there's many sick children. Yes, there's childhood cancers, but there's also childhood genetic diseases. There's premature children that have very sick in and out of hospitals their whole lives. There's many, many sick children, and I just wanted to point that out because I feel like I've had some comments along the years where people just assume, like when I was a pediatric resident, you have to take your history and you have to take your history, do your physical, and some of the history is a background past medical. So I asked his father, his baby was 6 months old, and I said, any medical problems in the past, any hospital admissions prior? I was like, no, she's 6 months old. I was like, would you like to see our NICU or PICU? I mean, we can't take these things for granted or assume. I mean, this is why there's a whole specialty of pediatrics and subspecialists for a reason. There's very sick children. We do see well children, but we also see sick children.
Those are the things that you tend to pick up at a sick visit or a wellness visit.
Yeah.
Because I remember picking up a 5-year-old who was complaining about arm pain. I think you remember that child.
Yeah, I remember that was
and then came in complaining of leg pain and ended up having leukemia.
And she looked very pale. She was very quiet. So when you touched her, because I remember you had me come in the next day too.
Yeah.
I just touched her leg, and the look on her face, you could tell she was in a lot of pain. That's why just watching the patients, she didn't say that hurts per se, but she winced you could tell. Very painful looking wince.
Yeah.
So
we ended up sending her down to Albany. And I believe at this point she's still receiving chemo. So it's been quite some time.
Yeah, at least a year, if not 2.
A couple years.
Yeah. Kids are born sick. Kids become sick. Just kind of realizing that it's not all just cute fun and games.
Right.
Like it is a serious.
That's the hardest part, though. Yeah. You're so busy, you don't have time to play with the kids.
Well, yeah, right.
When I worked as a nurse in pediatrics, after I fed them and bathed them, and they were like going to spend a little time before bed, we'd throw a sheet down on the floor, we'd put them down on the floor, and we'd lay on the floor and play with them.
Yeah.
You don't have that opportunity in the office very often to actually hold the children and play with them. And you haven't got time to necessarily interact with that baby, but only minutes because you have so much else that you have to get done.
And you have to do so much for them. Like once you come out of the room, there's a bunch of things you need to do for
immunizations them. And do whatever. Yeah. So that's to me, that's the disappointing part of the job. And I say that to parents quite often now. I have to go, but I could stay here and play with your son for hours.
I could say, sometimes I just jokingly say, you want to keep them here the rest of the day? But kids they're so innocent. You just look at their eyes. They're so innocent. They are innocent. I believe everyone's born innocent and pure, and they all look the same when they're born. They have different features and different skin colors and different, hair, but they cry the same way. They want the same things.
Yeah.
babies and children subsequently are even teenagers. They're innocent, they're pure, they are moldable, impressionable.
Yeah, they're sponges. Whatever their environment and the adults around them and other children around them instill in them is who they are going to be.
Yeah. And it's everyone. That's why it takes a village. But I have to say, though, I mean, we do get to see a lot more wellness and cuteness and funness than anybody else.
Yeah, we do.
It does make pediatrics so much more fun, interesting. We have, I think, a lot of job satisfaction in that regard. Because when a parent tells you, oh, I feel so much better now after coming here, and you said that to me, that's very rewarding.
Yes.
Just to help, because we may not always know the answer, but just the fact that we are listening is sometimes what they need. And I'm not going to lie. I mean, it is a lot more fun than a lot of other jobs in healthcare. To deal with children every day they do make it easier. The fact that your patient is a child makes it easy. My humble opinion.
I mean, they have their issues and you have to delve to sometimes, determine what the issue is. But I found that adult medicine is more difficult only because the adults are not always as honest as you would like them to be.
Children are brutally honest.
Brutally honest.
And sometimes I get nervous because they're going to point something out on me. Like,
they'll tell you if you have bad breath.
They'll tell you
They'll
about...
come right out and say it.
I'm afraid one day they're going to point out these white hairs, Joan. They're just going to say it. Dr. Majid, why is your hair turning white? But yeah, they're precious, and you do whatever you can for them because they are children.
And you try to help the parents, and you try to guide them toward helping the child grow to be that full-rounded, total person.
Because we could be that person that influences something good, hopefully. We just wanted to give people this glimpse into what we do, why we're here. Any final thoughts? Because then I was just going to wrap up with some resources for parents.
Well, my final thought is this. In this office, we have seasoned pediatric nurses who are excellent. They know their business. They will come and grab you if there's something not setting right with your child when they're in that room, getting them ready for us to see the child. So they're a major resource as well.
Yes.
We have to give them a lot of credit because they work hard.
Yes. And they are extremely crucial part of the team because they know that family too.
Yes.
And they know things. This is what they do all day.
Yeah.
So they know it and they're excellent at it and they're here because they love it. Like, you're not going to do this job unless you really love it.
You have to love children.
Yeah.
And many providers don't. That's why they're adult providers because they can't deal with children. And many nurses will say, "Oh, I can't do pediatrics. No, I can't. I wouldn't be able to deal with crying kids all day."
Yeah, right.
But when you actually are here in the office, there are not many children that are screaming and crying. I mean, you'll encounter a few here or there, but even a lot of these infants, even giving them immunizations, don't cry. So which is astounding.
Yeah, they do. Right?
It's the older kids that know what a needle is that give us the hardest time.
You have to hold down the 16-year-old.
And that's what the nurses do. And more often than not, they're able to get that child to accept that immunization, but they go in the room and attack two at a time. I mean, it's two nurses against one child.
Right,
So they're pretty convincing.
They are. They're good at it.
Yeah.
They're very good at it. And being a nurse is no easy feat.
No. And they have just as much paperwork in that computer to do as we do. So computers in rooms with nurses because they're updating meds and doing histories. It is what it is.
Yeah, it is. So I'll end with some resources because I think we're all guilty of Googling things. I try to avoid the temptation, but sometimes it's something to answer a question, but it's not always accurate. Most of the time it's not. So if you must ask somebody besides us, well, first, ask the pediatric provider your questions. So ask the child's provider. If you must look up, there are very good resources made just for parents. The American Academy of Pediatrics has, on the website, is another website called healthychildren.org. And it's every topic under the sun written by providers for parents. So it's like a little summary written in regular language for parents to understand, broken down, and it's all for parents. Anything from like a big lymph node to breastfeeding to seizures. It's all written down clearly what it is. And Up to Date actually has
information for parents.
Yeah, patients, parents, they have resources. And speaking of the American Academy of Pediatrics, if you are a bookworm, they have actual like textbooks for parents that they wrote out for parents. There's Caring for Your Baby and Young Child, and then there's a second one for the older age group. So they have like an actual, you can buy it, you can have it at home, you can read through it. It's written out just for parents. So these are good books. I mean, they have a lot of like older books from back in the day, but these are like the recent things that are good for parents. So if you want some other resources.
One other resource. There is a book that was written when I was in PA school.
Mm-hmm.
And one of my colleagues was was involved in the writing of it. It's called Our Body, Ourselves. And it talks about, it's good for adolescents and up. Starts out with puberty and takes you straight through, talks about all the STDs. I mean, it's written in layman terms, easy to understand. There are pictures. It's an excellent resource for your young adults, your adolescent, 13 and up, 12 and up. I used to keep it on my coffee table in my house. My son played guitar.
Yeah.
Had a band.
Mm-hmm.
They used to rehearse at the house.
Mm-hmm.
Everybody from the school was there. Every kid imaginable was there, listening to them rehearse. And then many of them would leave, but then the friends would stay. They'd sit in my front room and there was the book, and they start going through the book and would yell, "Joan, what does this mean?" It's really a good book to have, especially for parents, because it answers all the questions that the child might ask.
Yeah.
But also they can pick it up and read it themselves. So it's a good resource. It's called Our Body, Ourselves. And it costs about $20. It's not expensive. You get it on the internet.
Probably on Amazon, right?
Yeah.
That's pretty much where we can wrap up. I've been meaning to do this one with you. The care of children, what we're there for, and it's across the board. Whoever your child's provider is, this is what we do.
Yep. Any pediatric office does.
Yes, any family medicine office who sees children as well. Yep. This is what we do. Thank you, Joan.
You're welcome. Thank you for inviting me.